Hello, everybody. We'll do the last presentation of the day. I'll try to make it quick. It's almost 4. We're 45 minutes late. So I'm going to shorten the presentation a bit. If you have any question, it's a small group. Raise your hand and we'll answer your question. My name is François Séguin. I'll do the part of the presentation with Basma, my colleague. I'm the marketing manager for Biomérieux. Most of my career, I work on integrating lab system, pharmacy, AMR, all the different healthcare system. And what we're going to talk about today is the case of cumulative antibiogram locally, but in a regional setup or provincial setup, or even at the national level, what we could do and what are the barriers to get there. And keep an open mind, what we are going to talk about is the cumulative antibiogram, but it's also fully applicable to any other type of data that you would like to follow up in regional, local, or even national setup. So a quick overview, and I'm going to skip the first two. I think everybody is convinced of the value of cumulative antibiogram. Everybody is doing it. There's a value of having them locally. The big question now, if there's a value locally for cumulative antibiogram, why don't we have it at a higher level in a region, or half of a province, or a full province, or even at the national level? If you want to do surveillance, if you want to do trending on the resistance, there's a need to get there, to be able to have national data. That would be the ultimate outcome. Let's look at what we could do. So I'm going to skip those two. And so everybody's convinced that there's a value for cumulative antibiogram. So why we're not there? We're in 2025. IT is not necessarily an issue. The technology is there, but we don't have the data in terms of if we go to the provincial level and give us the cumulative antibiogram for the province over the last 6 months. They might be able to give you data for the last 5 years, but they're not updated. Same thing if you want to do surveillance for VRE, MRC, VR, and so on. We have data, but they are not necessarily complete. And we're going to review a few of those barriers, why they are there, and why they prevent us to do it right now, and how we could resolve them. So the first one is, in terms of cumulative antibiogram, everybody wants their own flavor. Nobody wants to have a standardized cumulative antibiogram. Every hospital is slicing and dicing the data a different way. They're presenting the data to the physician in a different way. They're filtering the data in a different way as well. There's no guidance at the national or even provincial level to standardize the way that the data are being reported. First one of the biggest barrier, if you want to standardize something, is to use the same coding system. Very simple, but let's say that you are in a region, you got 10 hospitals, 10 different systems. You probably have 10 different ways of naming an E. coli, 10 different ways of naming MRSA, 10 ways of naming piperacillin, tazobactam. So if you count like on a multi-tough, you got usually between 4,000 and 5,000 organisms. Multiply that by 10 sites, multiply by the quantity of antibiotic that you have, you got a big mess. So trying to standardize and make sure that the E. coli from one site is equal to the E. coli to the other site is the challenge of interoperability. And there's a lot of standard on the market that could be used. However, if we're talking about standard, LOINC is one of them, SNOMED is another one. Those standards were developed later in the game. So they were not developed 25 years ago when most of the LIS or EMR system were done. So basically, they develop or use an homegrown system, codification system, and we need to synchronize those code in order to be able to compare them. The other one, depending on the system in front of you, the capability to export data and the format is different. So you have systems that could export in PDF, other systems that are exporting in CSV, other systems that are exporting in other type of format that are not necessarily compatible. It's not everybody who's also following the CLSI guideline. Everyone is having their own way of exporting the data. In terms of exclusion, the example, the management of duplicate, how do we manage a duplicate isolate in the cumulative antibiogram? One site might manage it, the other site doesn't. Why? Usually it's a feature within the LIS or within the AMR that prevents you to do it. The other thing is that in terms of data, the data are across different platforms. If you're trying to extract data from the lab, sometime you're going to miss the specimen source, you're going to miss the collection site, you're going to miss the date of birth, you're going to miss a lot of information that will give you the ability to slice and dice the information in a proper way. As we speak right now, most of it are done manually, so you need someone that goes into your LIS or EMR, extract the data, play with it, do some modification, just to do the local reporting. So imagine that if you want to do it at a higher level, you need someone that will combine the data from the different site. Of course, if you do something manually, it's prone to error. It's a slow process, and that's why right now most of the cumulative antibiograms are usually older than a year. Another factor is that IT is costly. Most of the healthcare systems are running on old version that are not necessarily supporting standard in terms of interoperability. If they want to move to those type of architecture, it starts to be very, very, very expensive. We have a case in Quebec where they're trying to implement a new EMR for the province. We're talking about $3.2 billion. So it's difficult to get the money to get there. So there's barrier. How could we get around them? Because, as I said, we're in 2025. Technology is there. We could get there, but before we get the final result, there's a few things that should happen. First one, we should establish, let's say, by starting by regional, and then provincial, and then national standard to the coding system that shall be used in terms of interoperability in your region. First one, it could be LOINC, could be SNOMED, and also the type of communication that could be used to exchange the data. HL7 and FHAR are the minimum. At this point today, it's not all the system that could support that type of communication. Also, it should be aligned to another standard, which is the CLSI M39 guidelines for uniform reporting. We need, and something people forget when they try to do that type of setup is that, yes, you're investing a lot of time implementing the solution, but it needs to be maintained. Those code for antibiotic, the code for the organism, they're not static. They change over time. They change a lot. We think that the E. coli will be the same for the next 25 years. Not really. For multiple reasons, it could be an upgrade, it could be... So you need an infrastructure to maintain that type of setup. So it's part of when you invest money, yes, you're going to input money up front to implement, but you need to think about keeping the system alive and having someone or a body that will look at maintaining the solution. We should also foster collaboration in between the different lab and the different region in order to work on the same goal and share the best practice that we learned as we go. What we're going to go over shortly after with Basma, it's a few case studies that were done in Canada and around the world. Some of those case studies were a one-shot deal where they've tried something for a quick period of time. And we're going to go also with a more standard approach and a few solutions that we have at Biomérieux that are aligned with that type of setup if you want to standardize data, not only for cumulative antibiogram, but also if you want to do it for organism trending surveillance across multiple regions. Basma? So Basma is the IT product manager at Biomérieux.
All right, so, we'll be going over some of the case studies. The first one we're going to talk about is Ontario's Provincial Interactive Program, and this initiative consolidated antimicrobial susceptibility data from multiple hospitals across the province into a standardized interactive dashboard. And the goal was to make data more comparable across hospitals and allow for regional trend analysis, and also provide clinicians with real-time information on resistance patterns. So in 7 months, the dashboard was accessed over 2,100 times by more than 1,600 unique users from 37 different countries. And this high engagement highlights the platform's utility. So it improved access to comparable resistance data, it supported antimicrobial stewardship efforts, and it even generated international interest as a model for scalable surveillance. And the second initiative is the Smart Surveillance Program, and this is a 5-year Canadian cohort within a global program monitoring gram-negative pathogens in healthcare settings. It helped reveal key resistance trends like ESBL prevalence and Pseudomonas susceptibility, which directly informed stewardship strategies and policy decisions. And unlike the Ontario dashboard, the SMART program's approach was longitudinal, tracking trends over several years. And it's important to note that both initiatives were initially one-time effort in their respective settings. However, each demonstrated the value of cumulative antibiograms, whether for immediate clinical decision support or for long-term resistance monitoring and policymaking. All right, and now we will move to the Middle East to highlight national AMR surveillance programs in the UAE and in Jordan. So we're going to show how cumulative antibiograms are applied at a national scale. First, in the United Arab Emirates, they developed a robust national AMR surveillance network since 2010, following HUGLAS methodologies, and this network currently includes 317 surveillance sites and 45 microbiology labs. Over time, it reported more than 1.27 million isolates from over 662,000 patients, And by aggregating this data, the UAE can produce national cumulative antibiograms, which are then used to inform empirical treatment guidelines across the country. And this approach ensures that clinicians have access to standardized, evidence-based data when making treatment decisions. And next, we have Jordan's AMR surveillance system, or JARS, which was launched in 2017. It engages 42 surveillance sites distributed across all governorates of the country. And into 2022 alone, JARS reported 49,044 non-duplicate clinical isolates. Alongside these reports, the system generates annual cumulative antibiograms and resistance trend analysis, which effectively provides national coverage for AMR surveillance. And this allows policymakers and healthcare providers to monitor resistance trends and adjust strategies accordingly. And both of these programs demonstrate how large-scale standardized AMR surveillance can support clinical decision-making and public health policy through cumulative antibiograms. And they show the transition from hospital-level surveillance to a fully national perspective, which is critical for guiding empirical therapy and stewardship programs. So now that we have reviewed the national and provincial AMR surveillance program, we can transition into how this data is collected, integrated, and visualized in practice, which brings us to Clarion and other bioMérieux instruments. So Clarion, for those who are not familiar with it, is a cloud-based SaaS platform or clinical informatics platform that is developed by bioMérieux. It's designed to integrate, analyze, and visualize diagnostic or lab data, for example, microbiology, molecular diagnostics, and infectious diseases. At the core of Clarion is the ability to augment the value of diagnostic data, not just by collecting it, but by transforming it into meaningful and actionable insights. And it also supports infectious disease management by helping teams monitor trends in pathogen occurrence and resistance patterns. This allows clinicians to recognize emergent threats early and adjust treatment strategies proactively. It also helps labs optimize quality results, highlighting sample quality issues or ineffective collection practices, which enables teams to target process improvements and minimize repeat or invalid specimens. And it also drives lab performance by streamlining microbiology workflows and supporting movements in time to results. The labs can operate more efficiently while supporting patient-centered outcomes. So, building on that foundation, the Advanced Antibiogram Suite brings even more depth and intelligence to antimicrobial stewardship. The suite includes tools such as cumulative antibiograms, which helps improve the accuracy of empiric therapy, and the comparison of yearly antibiograms, which allows teams to monitor susceptibility results over time. We also have features like MDRO surveillance, MIC distribution dashboards, and respiratory pathogen analysis, which helps ensure therapy selection aligns with breakpoints, resistance mechanism, and clinical context. So, altogether, the goal of this suite is clear. It's to guide the use of appropriate therapy by providing integrated dashboards that monitor changes in organism occurrence and resistance patterns. The Advanced Antibiogram Suite helps clinical teams confidently select therapies aligned with real-world microbiology data. So Clarion also brings about cumulative antimicrobial resistance and surveillance capabilities. And these dashboards transform raw microbiology data into actionable insights for stewardship and for infection control. On the top left, for example, we have the Advanced Antibiogram View, for example. So this dashboard aggregates susceptibility data across organisms and antibiotics. It has a color-coded matrix, which makes it easy to identify resistance patterns at a glance. So there's, for example, green for high susceptibility and red for high resistance. And it helps clinicians and pharmacists select the most effective therapy and monitor emerging resistance trends. On the top right, we have the comparison of facility antibiograms. So here we compare cumulative antibiograms across multiple facilities or units, and it enables benchmarking and highlights variations in resistance profiles between locations. On the bottom left is the prevalent pathogen trend. So this dashboard tracks pathogen prevalence over time, It peaks and shifts in the peaks and shifts in the graph indicate outbreaks or seasonal trends, while the side panel shows percentage changes of key organisms. And the bottom right, we have geomapping. So this visualization plots resistance data geographically, and each point represents a facility with color intensity indicating resistance levels. So it allows public health teams to identify hotspots and implement targeted interventions. So beyond individual labs, Clarion, along with Maestria, can support national AMR surveillance strategies. Maestria is a microbiology middleware software solution that's developed by Biomérieux. It's designed to support the clinical microbiology lab workflow from specimen logging to final testing results by integrating instruments, LISs, generating reports, and providing data insights. It's actually part of the broader suite called Vision Suite, which aims to turn lab and hospital data into actionable information. So at the local level, Maestria connects directly to instruments and LIS systems, as I mentioned, automating data collection, and it ensures standardized interpretation according to global frameworks. And the standardized data is then aggregated and visualized through Clarion via the AMR surveillance module, which enables dynamic resistance trend analysis at regional or a national scale. And with this model, health authorities are equipped to develop national treatment guidelines, monitor AMR trends over time, and strengthen preparedness for emerging resistance threats. So in essence, this ecosystem transforms individual lab results into a coordinated national insight platform, which supports surveillance, stewardship, and public health policy in a unified and scalable way. So with the Clarion Surveillance Network, ministries of health gain real-time visibility into AMR trends. And the platform puts insights directly at their fingertips. It's not within weeks or months later, but in near real time. So one powerful capability within this system is the site-by-site comparison view. And the feature is essential because resistance patterns rarely look at the same at the same stuff across an entire country. But by comparing sites, health authorities can identify local variations in resistance trends, detect high-burden areas or emergent hotspots, and prioritize resources and guide targeted intervention where the impact will be most significant. And as I mentioned before, Biomérieux's Vision Suite is an integrated software ecosystem where you can connect diagnostic instruments, lab information systems, and hospital clinical workflows to transform the raw microbiology and molecular data into actionable insights. And our approach bridges insights from inside the lab to national level intelligence, creating value at every tier. We have national surveillance, which is a forward-looking solution to monitor and respond to emerging health trends at a scale. There is clinical decision support with LUMED, which empowers clinicians with patient-specific insights for faster and more accurate decisions. There's analytics for stewardship with Clarion, which drives responsible antimicrobial use, reduces resistance, and improves outcomes. There is workflow efficiency with Maestria, which optimizes operations to maximize productivity and reduce costs in the lab. And there's finally instrument management with Fireworks, which ensures asset reliability and performance across the network. And what sets Vision Suite apart is its multi-level impact. So there is local insights for immediate operational decisions. There is regional and provincial comparisons for benchmarking and resource allocation. And there's also national surveillance for policymaking and for public health strategy. So I will pass the mic to François.
It's more an open discussion. What do you see on the ground, in your lab, in your organization, in terms of gathering data? Nobody wants to talk?
I'm sorry, my name is Dave James. I'm from Life Labs. Before answering your question, where do you see AI playing a part in compiling some of these labor-intensive antibiograms?
It will be part of the solution, but I think it's going to be more on the long run. In terms of AI right now, I think the biggest issue that we have when we play with data, it's how do we certify that type of solution, because AI is really, really good at doing tasks, but sometimes out of the blue, it's generating something that doesn't make sense. So in terms of clinical data, it's hard to use it to standardize data as we speak right now. But the way that AI is going right now and the speed of development, probably in 5 to 10 years from now, it will be able to do that type of consolidation. But we still need to provide the data, and that step right now it's even difficult to get the data out from the different system within the hospital. But definitely the AI will be one way of helping on the long run.
Okay, another issue I'm seeing is the privacy concerns, right? And how do you navigate around that particular obstacle in sharing data from one institution to another? Does it go to one central database?
And depending on the level of data, what we were talking about Clarion, the first thing that we are doing is to stripping off all the patient information. So we're leaving only the clinical data with an internal number. So there's no link in terms of being able to retrace the patient. That's the first step. The second step, it's more a contract in between the different organizations to share the data, because as you said, there's depending on the province, the rules are different. If you go in Quebec, in Ontario, or in BC, it's not everybody who's sharing the data the same way. In Quebec, it's a bit easier because we have a standardized law that permit to exchange the data. In other jurisdiction, it's a bit different. It needs to be reviewed one by one.
All right, so the data that's coming out of Clarion is coming out of your AST instruments, right?
We have a two-pronged approach. We could do it directly from our instrument, and in that case, the interoperability issue is not there, because from us, we know an E. coli is an E. coli, and if we go to the other site, it's always the same thing. However, it's a limited number of transactions. We do the automated version of the AST and ID. If you want a complete version, including e-test, including Kirby and so on, you need to extract the data from the LIS or the AMR, and we could do the link also from that portion of the data. So we could tackle from the bioMérieux instrument, but we could do it also from the LIS or AMR, and when we do it, we could extract data from other vendor. So we could go with the data from BD or from Microscan or from other systems that produce ID and AST.
Okay, so not all institutions will report all their antibiotics. They have cascading rules.
Yeah.
And each institution have their own different rules, right? How do you navigate around that?
In one of the slides, the first thing I said, we need to standardize the way to report and to agree on a way to extract the data and present the data, because as I said at the beginning, everybody's doing it their way.
True. For us, Life Labs, we do have different clients, and some clients have good antibiotic stewardship programs, and they limit the amount or a particular antibiotic from being reported to their system, and I respect that. So how, for example, one of our hospitals doesn't want fosfomycin reported because they don't want the physician to treat with that, but others want that. And so it becomes very difficult then to be able to get data, meaningful data, when you have these kind of restrictions.
And depending on what is the goal of publishing the data, if it's for maybe Clarion is not the tool for physician, it's more a tool for surveillance internally within a region.
So without restriction, just raw data going through.
So we have other solution, like one of them is Lumed, that if we want to publish data for physician, it's a different approach. And then we could do something that is more customized by customer.
All right, thank you.
No other question? Nope.
I'll do my best in English. So in Quebec, we are all migrating on the provincial LIS. I am not on it in my own hospital. It will be next January. What I'm hearing from the others is that it will be harder to get our cumulative antibiogram with that LIS after. We don't really know what was planned for that kind of data extraction. I don't think it was in the plan when they
Thought about the system?
talk about the system, yeah. Because there is no policy about antibiogram storage in Quebec. We have a lot of policies around IPAC, but not really any about antibiotic stewardship. So I think there's a lack of vision there. But we will have the same system, the same code. So technically, I think we could do pretty standardized provincial cumulative antibiograms.
Yeah, it's a good point, and Quebec is probably the only province running a single database for the lab. All the other provinces or labs are running different LIS either in the same region or so it's difficult for them to do what you're going to do in Quebec.
Yeah, I would say there is one big exception. Our public health laboratory is not planned to be on this LIS. I think it's going to be a big hole.
Thanks. I think we're good. Oh, no, that's good. Sorry. Marie-Claude will do the end note.
So that's it. 2 days in this room learning a lot about stewardship. So just quick closing remark. On behalf of the team, the bioMérieux team, I wanted to thank you for your engagement over the past 2 days, and especially in this afternoon for the marketing session, for your questions, and most importantly, your commitment to advancing stewardship, innovation, and better diagnostics in Canada. What we've heard today reinforces one key message. Bridging the gap between science, operations, and clinical practice is possible, but it requires collaboration, data-driven decisions, and the courage to challenge traditional pathways. Whether through stronger AMS programs, meaningful antibiograms, or solid business case for innovation, each of us play a role in transforming patient care. So let's continue the discussion. Let's not stop until next year. And let's build connections. Let's keep the dialogue going and turn these insights into actions within our own organization. So thank you again for being here, and well, looking forward to seeing you next year.